starting.
We are live. A very good evening to one and all that are present here, and I welcome you all to another iteration of the YOSI Journal Club. This is the month of June. We begin this evening's Journal Club by introducing the team at YOSI, including the Governing Council, consisting of prolific leaders as well as the executive members, a core strength of pillars keeping the YOSI team alive pan-India. The concept of the YOSI Journal Club is manifold. However, it is mostly aimed at young residents, young fellows, as well as young ophthalmologists to teach them and to garner them and to train them on how to read, present, and as well as understand a journal article. The format that we follow here is where we assess the literature, in which case we pick up a journal and we define the problem, we specify the research question, we go into the definition of the variables and the selection of the subjects that was done in the paper. We select the appropriate research design, we analyze the data, and finally, we interpret the results according to the MARI format. So amalgamating all this, the format of the club, of the journal club is something like this. For every month, we have a mentee who is usually a young ophthalmologist, which may be a fellow or even a resident. And this mentee is assigned a mentor, and through a month-long program, the mentee goes through the journal along with the mentor, breaking it down, describing and deciphering the ins and outs of that journal. On the day of the presentation, on that day, along with the mentee and the mentor, we have a research expert as well as a group of panelists, which may be 3 or 4, that break down the journal for the audience. The format followed to break down a journal is the MARI format, which is the method, assignment, assessment, results, interpretation, and extrapolation, which is a step-by-step approach for reading the medical evidence that presents itself. With that, I would like to introduce the YOSI Journal Club team, which is led by Nupur Goel ma'am, myself, Rohit Modi sir, Bharat Gurnani sir, as well as a team of mentors which exists. If you want to present a journal article, I would request you to take a screenshot of this page and write to us at yosi.journalclub@gmail.com and send us your request, and you may be able to present at the next journal club as well. The journal club has gone through many, many iterations. We had started right in the beginning, almost nearly 2 years back, with glaucoma, endophthalmitis, cataract surgery, ocular oncology. This was followed by ophthalmology, With that, we ended our first set of journal club topics and we went on to our next season. In the second season, we started off with pediatric ophthalmology, went on to retina, followed by refractive surgery, followed by cornea. And now this year, we are with our third iteration of the YOSI Journal Club series. Once again, we began in March with cornea. In April, we discussed glaucoma. In May, we discussed retina. And today in June, we'll be moving on to cataract surgery. The article up for discussion today reads, Combined phacoemulsification surgery and intravitreal triamcinolone injection versus standalone surgery in patients with type 2 diabetes, a prospective randomized trial. This has been taken from the BMC Ophthalmology Journal, which has an impact factor of 2.086. Joining us today is our research expert, Dr. Shraddha Surekha, who is a cornea, cataract, and refractive surgeon from the Centra Clinic in Mumbai. Our expert panel, consisting of Dr. Bharat Gurnani sir, who is a consultant cataract, cornea, external disease, trauma, ocular surface, and refractive surgeon from the JUNE'23 Chikitsalaya in MP, India. Dr. Nilesh Kumar sir, who's the medical director at Madhavi Netralaya, and Dr. Devakar Mishra sir, who's the director at Swarna Jyoti Hospital in Lucknow. The mentor for this evening is Dr. Shriyadhar ma'am, who is herself a consultant of cornea and anterior segment at iCare Noida. And the speaker and presenter and the mentee for this entire long month, as well as today, is Dr. Survi Jain, who's a first-year resident from Mohana Institute, Delhi. I will be a moderator for the session. And with that, without further ado, I will hand over the mic to Dr. Survi to share her presentation and begin her article. Dr. Survi, can you share your screen?
Is my screen visible?
Yes, it's visible. You can begin.
Good evening, everyone. My name is Dr. Surbhi Jain, and I will be presenting the YOSI Journal Club for the month of June 2023. My mentor is Dr. Shri Adhar, and the article for today's discussion is Combined Phacoemulsification Surgery and Intravitreal Triamcinolone Injection versus Standalone Surgery in Patients with Type 2 Diabetes, a prospective randomized trial. It was published in 19 November 2022 in BMC Ophthalmology, a journal with an impact factor of 2.086. The study was conducted in Al Muassat University Hospital, University of Damascus, Syria. First, let's begin with the definition of the problem. That is, there is faster cataract progression in diabetics and suboptimal visual outcomes after phacoemulsification is seen in diabetic patients. According to WHO, out of the 1 billion people with preventable visual impairment, 3 million people suffer from diabetic retinopathy. Existing literature shows that subclinical increase in macular thickness occurs even after uncomplicated cataract surgery. Moreover, central macular thickness and best corrected visual acuity are affected by age and presence of diabetes in first month after the surgery. A randomized controlled European multi-center trial on the prevention of cystoid macular edema after cataract surgery in diabetics, also known as the ESCRS PREMED Study Report 2, compared the efficacy of perioperative treatment strategies, that is topical dexamethasone and brompheniramine with subconjunctival triamcinolone or intravitreal bevacizumab. And they found that diabetic patients who received a subconjunctival injection with triamcinolone at the end of cataract surgery had lower macular thickness post-operatively than patients who did not. Intravitreal bevacizumab had no significant effect on macular thickness. Cataract surgery causes oxidative stress, which leads to a decreased retinal oxygen tension and increased capillary hyperpermeability, leading to an upregulation of vascular endothelial growth factor or VEGF and disordered retinal vascular autoregulation, causing faster diabetic retinopathy progression and increased incidence of cystoid macular edema or CME, therefore justifying the use of anti-angiogenic or anti-inflammatory agents post-phacoemulsification. Now we'll talk about the Irwin-Gass syndrome, also known as the pseudophakic cystoid macular edema, which is caused due to surgical trauma, leading to a violation of blood-aqueous barrier with inflammatory response, causing an instability of vascular endothelium, a breakdown of blood-retinal barrier, ultimately leading to a collection of fluid in outer plexiform and inner nuclear layer, causing cystoid macular edema. The aim of the study is to investigate the rationale of triamcinolone acetonide injection at the end of phacoemulsification surgery in patients with type 2 diabetes and to evaluate the consequences and safety of the injection. The dependent variables of the study are central subfield macular thickness or CSMT, corrected distant visual acuity or CDVA, intraocular pressure or IOP. The independent variable of the study is intravitreal triamcinolone acetonide or IVTA injection at the end of phacoemulsification. Methodology: this is a prospective, single-blinded, randomized controlled clinical trial with a parallel design where the participants were blinded only. The Institutional Review Board and Ethics Committee at Damascus University, Damascus, Syria, reviewed and approved the study protocol, and the study adhered to the tenets of the Declaration of Helsinki. Written informed consent was obtained from the patients for participation in this trial. The inclusion criteria is as follows: 19 years or older and with type 2 diabetics patients were included. No diabetic retinopathy or mild to moderate non-proliferative diabetic retinopathy or NPDR at baseline. Candidates with visually significant cataracts were included. No restriction on the pre-operative central macular thickness was placed. Patients who presented between September 2020 and March 2022 were recruited, and only one eye per patient was included in the study. Exclusion criteria: the conditions predisposing to CME were excluded to prevent selection bias, such as uveitis, macular pathology excluding diabetic macular edema, RVO or retinal vein occlusion, complications during current or previous intraocular surgery, other pre-existing ocular pathologies such as pseudoexfoliation, Fuchs endothelial dystrophy, post-traumatic cataract, glaucoma or history of steroid-induced intraocular pressure elevation, or patients who were considered functionally monocular were excluded. Previous or ongoing ocular therapy such as topical NSAIDs, corticosteroids, or intravitreal anti-VEGF in the previous 6 weeks, or intraocular or periocular corticosteroid injection in the previous 3 months. Systemic conditions such as systemic corticosteroids, systemic bleeding, major systemic surgery in the previous 3 months, history of recurrent or recent cardiovascular accident, myocardial infarction, or thromboembolic events were also excluded. Preoperative assessment was done 2 weeks prior to the surgery, and patients were mainly characterized in 2 groups based on demographics, age, sex, HbA1c level, and diabetes control method. Examination was done to establish baseline CDVA, that is corrected distance visual acuity, and subjective refraction was done, which was later converted to the logMAR equivalent. Further examination was done using Goldmann applanation tonometry, dilated fundus examination, and OCT was done using the OCT spectralis. Central subfield macular thickness that corresponds to the mean CSMT in the central 1 mm area was reported according to the ETDRS retinal thickness map. And patients who had visually significant preoperative cataract had their funda evaluated at day 1 through 1 week postoperatively according to corneal transparency. The diabetes control methods that were used were diet and lifestyle modification, oral hypoglycemic drugs, which was the most frequent method, and insulin, which was the least used method. Random allocation to treatment groups, that is, the IVTA injection, and the no injection group was done using computer-generated random numbers. In the IVTA group, patients were given an intravitreal injection with 4 mg on 0.1 ml preservative-free triamcinolone acetonide injected 3.5 mm posterior to the inferotemporal limbus with a 27-gauge needle at the end of surgery. While in the control group, no sham injections were used in order not to jeopardize the eye to injection complications and risk. Patients were not informed about the applied treatment until 4 weeks postoperatively. Analysis of the data was done using SPSS 25.0. G-Power program version 3.1.3 was used to calculate the sample size. Kolmogorov-Smirnov test was used to check the normality of data distribution. Friedman's ANOVA test by ranks and ANOVA test for repeated measures was done for longitudinal comparison between CSMT, IOP, and CDVA at baseline and at each study point. Intention to treat analysis was adopted. A p-value less than 0.05 was considered statistically significant. Alpha value was considered 0.05, statistical power of 85%, apart from cases where Born-Ferroni correction was adopted. Enrollment, 74 patients were assessed for eligibility, out of which 6 were excluded as they did not meet the inclusion criteria, and 2 were excluded who declined to participate. The remaining 66 patients were randomized and allocated to 2 groups. 31 patients were allocated to the IVTA group, that is the intervention group, and 35 were allocated to the standalone phacoemulsification group or the no injection group. During surgery, 10 patients in the IVTA group and 6 patients in the no injection group suffered from perioperative complications, including PCR, granulosis, and incomplete cortex removal. 2 patients from the IVTA group and 3 patients from the no injection group was lost to follow-up, and 1 discontinued intervention in the IVTA group due to myocardial infarction. The remaining 21 patients in the IVTA group and 29 in the no injection group were included for the final analysis. Clinical and demographic data of study participants shows that the 2 groups were homogeneous in terms of sex, age, HbA1c levels, and the diabetes control methods. The raised HbA1c reflects the uncontrolled glycemic status in both the groups. For results, post-operative checkups and tabulation of data was done at 1, 3, and 6 months, and it was done along the lines of CDVA, OCT for mapping the central subfield macular thickness, fundus examination to assess diabetic retinopathy progression, Goldmann applanation tonometry, and adverse effects including inflammation and endophthalmitis. Comparison of CDVA at different study points shows a p-value less than 0.001, which indicates a statistically significant difference between the 2 data sets, and the mean rank, which increases significantly higher in the IVTA group, showing that the gain in visual acuity is higher in the IVTA group at 6 months post-op compared to the no injection group. Comparison of CSMT at different study points shows that the post-operative CSMT increase of 30% from baseline is seen in about 24% of patients in the no injection group, while CSMT values remain distributed vaguely in the IVTA group, as seen by the line chart. Dilated fundus examination shows that preoperatively, most patients in both the groups fall under mild to moderate NPDR, while compared to 6 months post-op, more patients progress to severe NPDR and PDR in the no injection group compared to IVTA group, where most patients have moderate NPDR, as seen in the bar chart as well. No significant swings in IOP were seen, and no patients required specialized glaucoma treatment. Adverse events: patients who developed severe postoperative inflammation received topical prednisolone acetate for 2 weeks. If severe inflammation persisted, dexamethasone phosphate were added and the patient was transferred to the uveitis clinic. Endophthalmitis: no incidence of endophthalmitis was recorded during the 6-month follow-up in the study. Endophthalmitis and non-infectious endophthalmitis are claimed to be complications of all intravitreal injections and not of IVTA itself. For the purposes of discussion, any diabetic macular edema seen post-operatively was assessed using OCT and divided into center-involving and non-center-involving diabetic macular edema, where a central macular thickness of 2 standard deviations above the normative study population of diabetics without macular edema was defined as center-involving edema. Any clinically significant macular edema was treated with intravitreal bevacizumab, while any proliferative diabetic retinopathy or PDR or any severe NPDR was treated with pan-retinal photocoagulation, that is PRP. So the need for further intervention post-surgery shows that the more patients in the no injection group, that is 48.3%, calculated by the Fisher's exact test, required any interventions post-operatively compared to the 23.8% patients in the IVTA group requiring any intervention. To conclude, greater increase in CDVA in the IVTA group is seen compared to the control group. In IVTA group, we noticed the decrease in CSMT on OCT that was most significant at 3 and 6 months follow-up visits and was most noteworthy when pre-op CSMT value was more than or equal to 300 micrometers. Increased central subfield macular thickness of 30% from baseline in the no injection group is seen after the surgery, and there is decreased diabetic retinopathy progression in the IVTA group. Author's interpretation: cataract surgery can be an ideal setting for combining the two procedures in order to reduce the patient's potential risk of endophthalmitis and to improve patient convenience. In addition, combining phacoemulsification and triamcinolone injection has shown clear cost effectiveness in the ESCRS PREMIT study report 2. Author's limitations: relatively small sample size, uncontrolled preoperative glycemic status in most study participants, only study of the central 1 mm zone of the ETDRS map, which was relatively thick at baseline in both the groups. Post-operative treatment were based on a case-by-case basis by the unblinded investigator. Coming to the Mari assessment of the paper, method: study question is well defined. Study was conducted among Syrian population. Sample size is 66 patients and study period is well defined. Assignment: single blinded study. Computer generated random numbers were used to randomize patients on a 1:1 ratio, and simple allocation concealment was performed by the closed envelope method. Assessment: primary outcomes were changes in CSMT and diabetic retinopathy progression. Other investigated outcomes include CDVA as measurements of efficacy, IOP, and endophthalmitis as measurements of safety. The results: enhancement of CDVA is more significant in the IVTA group. CSMT is decreased in the IVTA group, especially at 3 and 6 months post-op. Decreased progression of diabetic retinopathy post-operatively in IVTA group. Interpretation: IVTA provided a slowdown of diabetic retinopathy in the study group population without significant adverse effects, it shows merit as a phaco enhancer in diabetic population. Extrapolation study is done with a relatively small sample size and cannot be extrapolated among diabetic patients with well-controlled glycemic status or in patients without significant retinopathic changes. The limitations: mean preoperative CDVA is 6/120 or a logMAR equivalent of 1.3 in the control group as opposed to 660 or logMAR equivalent 1.0 in the injection group. The rise of CSMT after phacoemulsification is a transient phenomenon which is seen in diabetics and non-diabetics alike. Lastly, I would like to thank YOSI, especially Dr. Anujit, for giving me this opportunity, and Dr. Shriya for her constant encouragement and guidance. I would like to thank the panel members for their attention and the audience for their time. Lastly, we'll end with the questions for the panel. What grade of diabetic retinopathy warrants the use of an intravitreal injection post-phacoemulsification? And will the use of IVTA decrease the frequency of intravitreal anti-VEGF given to diabetic patients with moderate to severe NPDR? Thank you.
And thank you very much, Surbhi. Can I request you to stop sharing your screen? Firstly, that was an excellent presentation, very lucidly broken down and explained for the audience. This is a very pertinent topic. And I'd also like to take this opportunity to ask the audience present here, if anyone in the audience is performing routine IVT injections along with phacoemulsification, please do write it in the chat box. We will be discussing this. In the meantime, I will just be sharing my screen and inviting our research expert for this evening, Dr. Shraddha Surekha ma'am, to elucidate and break down the statistical aspects of the topic. Dr. Shraddha Surekha is a cornea and anterior segment surgeon who is based at the Centra Clinic in Mumbai. She has done research in stem cell transplant and keratoprosthesis for corneal disorders and has a number of publications both in national as well as international journals to her name. Currently, she's an anterior segment surgeon specializing in doing complex cataract surgeries, cornea stem cell transplant at her center in Mumbai. With that, ma'am, I'd invite you to share the research aspects and the statistical analysis of this paper.
Okay, thank you, Dr. Anujit, for the introduction, and Dr. Surbhi, excellent presentation of the entire article. So I'll just share my screen now. Dr. Anujit, you'll just have to help me if the screen is visible appropriately.
It's visible, ma'am. I'm just waiting for it to enter full screen. Yes, ma'am. It's in. You can go ahead, ma'am.
Right. So, so when we look at a journal article, Dr. Surbhi spoke about the MARI format, and essentially it gives us a very nice framework to kind of analyze any scientific literature in a very systematic manner. And the outcome is that you get to know logically what are the strengths of a certain study, what are the weaknesses. And if you can logically in your process of reading the article come out with those strengths and weaknesses, you can have a very personalized interpretation of that article rather than depending on other people to interpret it for you. So when we look at the study question of this article, it was pretty well defined, and their inclusion criteria were very detailed, exclusion criteria were defined. But I thought that they had included patients with no diabetic retinopathy, mild and moderate, and those kind of made the entire thing a little non-specific, as in when you are treating a patient, you would want to kind of know that what is to be done in a no diabetic retinopathy patient, mild and moderate. So I think that those should have been kind of differentiated very nicely. They have later on in the results section tried to differentiate those, but then the numbers become very, very small. So in order to kind of make it look like a good sample size has been used, if you club all this, I don't think it would, it makes that much sense. Then the macular thickness pre-op also wasn't an exclusion criteria. And I thought that that should have been taken into consideration, though later they have taken that into consideration, though the retina specialists would be able to tell whether that is, what they've done later in the result section is appropriate or not. The other thing which I felt they could have excluded were patients with high HbA1c levels or with kidney disorders, which they have not mentioned. So those can have kind of confounding results, because patients with very bad sugar control with high HbA1c levels, they may be more predisposed to macular edema. Also patients with kidney disorders. Now, the intraoperative complication rate was pretty high. They did exclude the patients which had intraoperative complications from the analysis. But if we just go at the basic data, those rates are pretty high. If for any surgeon. So was it a single surgeon who operated, or were there multiple surgeons? Were there surgeons in training? So that should have been specified. Maybe a single surgeon probably, or that would have been better. Now, the post-op protocol again could have been specified in a better manner, that whether the patients were given these steroids for that long, whether inserts were added for the patient in the pre-op, in the post-op routinely. Also, in the intraocular pressure measurement, they've mentioned that they've excluded patients with high IOP or patients on anti-glaucoma medications. But when they have discussed in the results section, they've stated there were certain patients who were on anti-glaucoma medication. So there was a slight discrepancy there. Now coming to the statistical tests. The statistical tests are very nicely mentioned in the methodology section. Now, when you kind of calculate the sample size, they have mentioned in detail about a certain, the alpha level, about 85% significance. So they've mentioned it very nicely. Okay, but what I have found that when we look at the sample size calculation for this kind of study, I am going to try and look at the macular thickness as being my primary outcome measure. Then I will define, okay, say 300 macular thickness is normal, and suppose it becomes 330, that would be abnormal. I'm just using random numbers here. So that 30 would be a factor with its standard deviation, which you will use for the sample size calculation. And this detail is not mentioned clearly, and that should have been mentioned clearly. Now, once you get that sample size, again, they should have mentioned that we expect so many patients to drop out of the study because of, say, intraop complications or not follow up. And for this attrition, we've added these many patients, and that's how we've calculated the sample size. That would give more authenticity to the entire process. So sample size calculation needs, further elucidation. Now, when we look at the data, just to give you a broad idea, you should classify data into categorical or numerical, and then you can just take a screenshot of this, and then categorical you divide into nominal or ordinal, and numerical into discrete or continuous. Now, when we have any numerical data, you have to kind of know whether it is a parametric data or a non-parametric data. And they have nicely mentioned that they have used a KS test to know which data is parametric or not. So that is pretty nice. Then we also need to figure out whether there are two or more groups and whether it's paired or unpaired, which is pretty easy. So what they've done now is that in the table assessing the primary outcome measure, they've used the Friedman's ANOVA test to calculate the difference in the macular thickness, whether it's significant or not at different time points. And if we look at the screen, we would know that it is numerical data, it is paired, and it has more than two groups. So they've used Friedman's ANOVA test. So that is correct. Then they have gone to say the difference in the visual acuity. Now again, they've used this more than two groups Friedman ANOVA test. Now, the point of kind of reiterating that they have used the appropriate tests and how one can figure out in the process of reading the article whether or not the authors have used the appropriate tests. There is an excellent article in IGO from which these tables have been taken. And once you have those with you, you can read up any article and then compare it with this table, and you would know whether the author has used a correct statistical test or not. Some of the common mistakes which the authors make and you should avoid making is not to consider whether the data is parametric or not, because then if you look at this table itself, if the data is parametric, tests are different. If the data is non-parametric, the tests are different. So those things need to be kept in mind, and this will help you if you design a study of your own too. So to conclude, the statistical tests used in this study were quite appropriate. The sample size calculation, though, it needs further explanation. I feel the numbers seemed very small to interpret the data. So they should be backed by good reasoning of why the sample size was taken. And certain areas in the methodology, like the intraocular pressure, they were, not very correctly mentioned in the methods versus the results section. So from here, I'll go back to Dr. Anujit, who can now introduce the other speakers. Thank you.
Thank you so much, ma'am. That was very well elucidated, especially the aspect about the sample size not matching the results and having too many patients in the no DR and the mild DR category to start off with. With that, I'd like to share my screen once again, and I would move on now to the expert panel. And specifically, I would like to invite Dr. Nilesh Kumar, sir. Dr. Nilesh Kumar is a KMC Manipal, JNMC Belgaum, Lotus Hospital, Coimbatore alumnus, and he has been trained in retina from LEH Coimbatore and DEH Patna. He's now the medical director of Madhavi Nethralaya, and he has innovated a novel smartphone-based gonio imaging device, which is known as a Digis Pro, which has been awarded at multiple innovator sessions. He has a special interest in academics as well as research, and has authored numerous papers in various national and international forums. His current area of interest includes smartphone imaging and medical retina. Dr. Nilesh, sir, I would like to invite you to share your screen and to discuss the positive aspects of the paper.
Thank you, Anujit, and very nicely conducted session. And I would like to congratulate Dr. Shurbi also, because in such a young stage, she has spoken very nicely. She was very confident in her speech, so kudos to that. And most of my work has been done by Shraddha ma'am. She has the most important aspect, the positive aspect of this paper is its statistical analysis that they have done painstakingly good. I'll come to other aspects now. So coming to introduction, the introduction is actually well abbreviated. The aim of introduction is to introduce the audience to the disease that is required, that we are discussing, and then the aim of the study, the introduction should come to the aim where they are trying to point to a pertinent lacunae. So is there a lacunae? Does this study even needed? Is the study even needed? So yes, there is a lack of evidence in the studied population regarding the utility of an additional intervention, that is IVTA, in a routine surgery, that is phacoemulsification, to enhance the outcome. Now, everybody will say that there have been numerous studies in past which has been done in other population. So will it matter in different races? Yes, it does. So, like in MIGS and ALT, in dark pigmented races, it is different than a white population. Even in advanced IOL formula, now we are seeing that the Asian population is having a different calculation when compared to European and Asian American cohort. So we need these different kind of studies in different population to validate that yes, this intervention is really required, or it really works in this population. Apart from that, this paper is coming from Syria, which is a war-torn country. So economics play a mighty role in the in any outcome. because the patient might not come for a follow-up if the DR progresses. So does IVTA stops the DR progression? And this was the question I think Surabhi also put in the end. Now coming to methodology, first thing first, it was registered with clinical trial registry. That is a very big thing. It itself is a surrogate that the protocol at least was well framed and the research was conducted well. Now it was a prospective randomized single blinded trial. It is not an audit of cataract registry as we have seen in other published paper, like an audit of European registry or an American registry. So doing that in a prospective study in a real world study is very difficult, and kudos to that they didn't keep it double-blinded study, because that will again increase the risk. You are giving a SAM injection in real world, which really is not justified ethically. Now randomization was done well, and they had well-defined exclusion criteria. So patient with any confounding factor they had excluded. So all this made the methodology really lucid and very to the point. Yes, I agree that they have not classified no DR, DR, and mild to moderate DR, but that might be the next step. Somebody might take up a study later. At least this study, which is the first study, at least provides a base for the further study to be taken up. Now, there are well-defined primary and secondary outcomes. Long follow-up of 6 months is there. For a cataract follow-up, 6 months is really good, because incidence of pseudophakic CME is maximum at 6 weeks and resolves by 6 months. And DR progression also peaks from 3 to 6 months. So any change that is happening via these two pathology will have its effect by 6 months, and we have seen the result that at the end of 6 months, the IVTA is having a superior outcome than the no IVTA group. And they had well-defined rescue treatment criteria. They had exclusion of steroid-induced glaucoma cases, though, as ma'am pointed out, that it was not very well-defined. And a good consort chart was showed how they had included the patients. Now coming to statistical analysis, they had actually appropriate formula for all the variables. They had, because there was dropout, they had used imputation. Imputation is where you have a missing data. The patient didn't come up at follow-ups for say at 1 month, but he came at 1 week and they came at 3 months and 6 months. So how to fill that data? So they had used an appropriate technique for this, where the last observation was carried forward or the next observation was carried backward when they saw that these are having a similar outcomes. And this can only be done when the dropout rate is less than 15%. And here the dropout rate was in tune of, I think, 12%. So apart from that, different appropriate correlation parameters were also used as ANOVA trials, ANOVA formula and all. So statistical analysis is actually the highlight, and anybody who is willing to conduct a study should see that how in the same study you can have multiple different formula to be used for different parameters. Now, coming to results, they had an extensive data set. The well layout parameters were given in subsection, so you can really know they have emphasized on each point. And similarly, the graphs were also focusing on single parameter, so it can be easily assessed. And non-significant results were also shared. So as you can see that yes, rescue injections or rescue treatment was not clinically significant, but numerically it was less in the non-IVTA group, but it was not clinically significant. But still that result was shared. So it is very important that, okay, you are getting better outcome, better central subfoveal thickness and better visual acuity, but you might need the rescue treatment in similar quantification as in no IVTA group. So, sorry. Apart from that, coming to discussion, that is the last part, the rationale behind choosing the additional intervention was well provided. There was comparison with other published material for different interventions. So they had actually compared with other intervention that is available, that is anti-VEGF agent and even dexamethasone implant. Discussion of the same agent via other routes like subconjunctival depot of triamcinolone was also discussed. And in secondary outcome, the studies supporting and disparaging the current outcome have been quoted. That shows a balanced writing approach, that okay, they are not trying to prove a point, but they are trying to give a focused approach and balanced approach to the audience. And the apt conclusion was given with a clear take-home message that okay, this is going to be a phaco enhancer for you. So that is a well-written discussion. Thank you for your time. And back to Anujit. And before I conclude, I would like to answer the question that Survey put in the end, that we really don't know, because the study population was not there for moderate to severe NPDR. But there are DRCR protocol and that and other studies, real world studies that show that yes, IVTA does slow down the progression. Even intravitreal anti-VEGF injection that are injected along with diabetic retinopathy, they show they slow down the progression, but nothing beats the control of diabetic retinopathy before doing a phacoemulsification, because phacoemulsification will add to the stress. So better to control it and then go for a two-step procedure.
Thank you so much, sir. I think you've highlighted the merits of this study very well. The fact that it was a prospective randomized single-blinded study is a huge advantage, and the results can be used by us and extrapolated for our real-world cases. So being fair to the article, just like we have praised the article, it's time to look at the demerits of this study. For that, I would like to invite Dr. Devakant Mishra, sir, to discuss the demerits of this study. Dr. Devakant Mishra is currently the director at Swarnajyoti Eye Hospital in Lucknow and a long-term member of YOSI, being the past secretary and now the current vice president. He is also a member of numerous societies with numerous published papers to his credit. With that, sir, I'd like to invite you to discuss the demerits of this paper.
Thank you so much, Anujit. And very valid points have been discussed so far, and beautifully presented by Dr. Surabhi. So there are a lot of demerits that I could point out from reading the article. One, of course, has been pointed out that it is a very small sample size. So it is very difficult to get a meaningful information with this kind of sample size. Another thing, they claim that their patients, it's a homogeneous group and the patients are well matched. But I see that Dr. Shraddha had also pointed out that it's a very wide spectrum of diabetics that they have taken into consideration, as wide as from no diabetic retinopathy to moderate grade of diabetic retinopathy. So let's take the worst case scenario. If all moderate diabetic retinopathy patients land up in one group and all no diabetic retinopathy patients land up in the other group, then it will be very difficult to get a meaningful information from the study. So the stage, ideally, the data, the results should have been stratified as per the diabetic state, the diabetic retinopathy status, and the initial CMT thickness. So the preoperative CMT thickness was, there were no restrictions that they have said that there were no restrictions in the CMT thickness. So these two parameters should have been very well defined, and patients should have been matched according to these, right? So I have, as a retina surgeon, I have some clinical experience with such cases, but somebody who's using this article to form a clinical opinion or clinical understanding, then it will be very difficult for that person to, get a very exact information from this paper. Another thing in the history, I found out that they have not given particular importance to the kind of, anti-diabetic treatment that was going on in terms of specifically the oral hypoglycemic that was used. There are certain oral hypoglycemics like pioglitazones, which is known to increase DME, right? Then a patient switching from oral hypoglycemic to insulin therapy will have an impact on the diabetic status or the diabetic retinopathy status. So this was also not considered or elucidated properly. Another thing was the duration of the surgery. They have done a good job by excluding the complication and excluding the complicated cases. But from my understanding and from a general understanding, we know that these surgeries, which are maybe there is no known complication in the surgery, but it is taking more than usual time, might have a greater progression of diabetic retinopathy. So the duration of the surgery, the type of surgeon that is performing, that could have been taken. I know it will be difficult to incorporate that point, but this is also a very important factor. Now, the systemic control during the study up till 6 months is also very important, right? So if a person maybe was maintaining a very good systemic control because he was planning a surgery and then lost control over his glycemic status. So that will have an impact on the results that we are looking at. Then they have, this is a case control study where they have compared uh, the steroid injection versus nothing. I think it would have been more meaningful if it had been compared to an anti-VEGF or something like an Ozurdex implant, because they have focused this study as a low-cost option in managing the diabetic retinopathy progression. All of us know that something will work compared to giving nothing to the patient, right? The information that we are trying to extract from this paper is whether can we go for a low-cost option or not, right? If you're not giving anything to the patient versus tricot, triamcinolone, I'm sure it'll work. But how well it is faring against something like an anti-VEGF agent or an implant, that could have been this opportunity could have been utilized to explore that thing as well. Another thing is that we do not have any information on the OCT biomarkers or the OCT data, what kind of CME was there. Now we have, as our understanding has increased, has gotten better, we know there are certain biomarkers where a steroid will work better and where an anti-VEGF will work better. There are choroidal biomarkers which will help us in guiding whether an anti-VEGF will work better or a steroid. So those things might have been also included in that study. So overall, yes, it gives us this a broad point that an anti-inflammatory agent will work, but in what kind of patients it will work, in what cases it will not work, these kind of information we are unable to gather. So I think yeah, it's a nice study, but not very meaningful, I feel.
Thank you so much, sir. I think two good points put out by you is one about the glycemic control 6 months post-operatively, as well as the duration of surgery, because we know that there are fast surgeons and there are good surgeons, and those do not usually equate to the same thing. So many surgeons who are slower surgeons would have an impact on the final outcome of the cases. With that, I'd like to move on to our third panel member. I'm so sorry. I would like to invite Dr. Bharat Gurnani, sir, to discuss the recent advances and the relevant aspects or the alternative approaches that can be employed in a case like this pertaining to this paper. Dr. Bharat Gurnani, sir, needs no introduction. He's currently a cataract and cornea trauma external disease refractive surgeon at SNC Chitrakoot in MP, India. He has more than numerous publications to his credit, including 270 peer-reviewed articles, and has reviewed over 500 papers at various journals, with his keen interests including microbial keratitis, keratoconus, dry eye ocular trauma, and lamellar surgeries. He has won more than 25 awards at national and international forums, including some of which, but not limited to, are the AIOS International Heroes Award, the Best Paper Awards at AIOS, including Best Physical Poster Award and Best of IJO Awards. With that, sir, I'd like to invite you to share your points.
Hello, I'm audible.
Yes, sir, you are.
Yeah, thank you, Anujit, for that kind introduction, and thank you everyone for giving me this opportunity. So I'll just go through a few points like about the article first, then I'll discuss few studies, and then I'll put my perspective regarding the patient profile. So if you see in this article, taking the negative points first, maybe the sample size is slightly smaller compared to could have been more, so give more detailed evidence regarding the study, although but it's just a randomized trial, so that holds promise. That's why it can be taken into consideration regarding evidence-based studies. So another thing is that all the good thing about the article, they have excluded the complications. Okay, so that could have been bias in governing whether really the triamcinolone acetonide is working or not. Third thing is that they've used triamcinolone acetonide steroid compared to anti-VEGFs. Like previous majority studies, if you see, they've used bevacizumab or the other aflibercept or other anti-steroid or triamcinolone. But here they've used triamcinolone acetonide, which is an anti-inflammatory agent. So that will give you I think better results in pseudophakic CME compared to like anti-VEGFs. Another thing which I believe the article has not discussed, how this article stands out different in compared to other studies. Although they have mentioned the negative points as well as the positive points, like how this adds good value to the, although it's like they are giving evidence from a particular center, but how this differs from the previous studies. So now, majority all the other points have been discussed by the previous panelists and the mentors. So now I'll come to like few studies. I'll quote like what has been described in the literature. So there was a study in Journal of Current Ophthalmology which discussed the role of combined phaco and intravitreal injection of bevacizumab in prevention of post-operative macular edema in NPDR patient. So they concluded, and the sample size was good, like 71 patients, and it was a prospective RCT only. And they concluded that IV bevacizumab during phaco would result in decreased central macular thickness in patients with no DR or NPDR and without macular edema in the early post-op period. This effect would no longer persistent at 3 months. So they had a like result after 3 months, the macular edema came back to the normal. So they concluded that initial transient phase, this may work, but may not work after a period of time. Okay. So another study which discussed the role of it was a retrospective study published in Journal of Retina. They discussed like when they did combined phacoemulsification with intravitreal bevacizumab and triamcinolone acetonide injection in diabetic patient with CSME and cataract. In this study, they have excluded CSME basically. So they found that phacoemulsification with intravitreal bevacizumab or triamcinolone acetonide also decreases CMT and causes a gain in visual acuity and reduces central macular thickness, gain in visual acuity in diabetic patient with CSM in cataract. And that was around 22 patients, but the data was small to conclude that. And then another study which was discussed was another in Journal of Retina with phaco with intravitreal bevacizumab injection in diabetics with macular edema and cataract. So this was again concluded that it reduces the central macular thickness and improves the vision. So majority studies have claimed that these anti-VEGFs and the triamcinolone acetonide work very well and should be given. And there was a systematic review and meta-analysis published in Journal of Ophthalmology with the intravitreal bevacizumab and intravitreal ranibizumab. They gave, and there were 9 RCTs. They took 9 RCTs and 3 non-RCTs, and they found that intravitreal bevacizumab or ranibizumab treatment immediately after cataract surgery may represent a safe and effective strategy. So that can be given immediately after the surgery as well, and maybe during the surgery also. And some patients, some of the studies have described the outcomes of uncomplicated cataract surgery on central macular thickness in diabetics and non-diabetics. They have segregated the groups into one group into healthy subjects and another group into diabetics with phaco and foldable IOL. But they found that there is no statistically significant difference in central macular thickness between normal subject and diabetic subject without DR, pre-op and early post-op period after uncomplicated phaco, basically. So, but now recent studies have been like phacoemulsification with dexamethasone intravitreal implant in diabetic patient, which was recently published in European Journal in 2021. So they concluded that dexamethasone intravitreal implant combined with phaco may be a safe and effective approach for morphological outcomes in diabetics and coexisting cataract and macular edema. And another study which was published in Journal of Ophthalmology also concluded the same. So now there have been recent advances like with the drugs in the pipeline, such as new sustained release drug implants, and there have been anti-VEGF which have been targeted with Tie2 receptor modulators, and some people have tried gene therapy, but still the results are like the studies are awaited. But these have not been tried in studies with the phaco with foldable IOL and in diabetics or non-diabetic. So these may be the future options, and they may give you some better insight. So now, considering the practical aspect of this study, I must say, like when we approach a patient that already, I think Devagam sir spoken about that the duration of surgery And another thing I would take into consideration the cataract grade, the other complicating factors like pseudo exfoliation, small pupil, and other things used like iris hooks used during the surgery, time taken, and all these may promote more inflammation and more chances of diabetic macular edema or pseudophakic CME post-op. So now the decision is to whether I need to combine that patient with intravitreal drug or not, because convincing a patient for an injection which he may not be like, he may not be willing with you, okay, because if you suddenly tell him you have a mild grade of DR, then he'll say, okay, I'll wait, maybe if have something I'll take. So in that patient, just considering all these factors, if the grade is more, if there are more risk factors, I may combine a intravitreal implant even in a intravitreal drug in a mild to moderate DR. What we have been earlier seeing, like mild to moderate DR, majority people in a routine uncomplicated phaco surgery, they're not combining the intravitreal drugs. So, and another thing which has to be taken into consideration, like is there is CSME or is there is a macular edema or not. So OCT plays a good role. Third thing is pre-op patient, as Nilesh sir told, pre-op control of diabetic with lasers and other intravitreal drugs would be far better. So overall, this study, I must say, it's a good study because there are very few studies which take mild to moderate DR into consideration. It gives a good evidence that if we combine the drugs, if we combine intravitreal triamcinolone during surgery, it may give you a better result post-op, and we can counsel the patient pre-op. These patients may not progress to devastating complications in the end, and taking into consideration that diabetic control is good, fairly good pre-op. So this is my take on this. Thank you.
Thank you. Thank you so much, sir. So I'd like to put forward a question to the panel members that is present. So the first, it's directed to all the panel members. The first question would be that in your practice, being prolific surgeons yourself, what is your take on this scenario? How often do you use IVTA during your cataract surgeries? That is one part of the question. The second part of the question is that I think we've all faced this scenario where we've seen this really nice NS3 cataract and the patient is a diabetic, and after advising the patient cataract surgery, the patient has a dry OCT, but then the sugars are somewhere near 250 or 300, so we defer surgery. But then the patient does come back after maybe a fortnight or something with the sugars below 200, and we do take up this patient for surgery. So in a scenario like this, would you prefer giving an IVTA where you do not know whether the patient would be convinced for an intravitreal injection? The patient is not from a very good socioeconomic background. So this typical case where a patient has high sugars and has finally controlled his sugars and you're going to take up the patient for surgery, what would be your approach? I'd like to just start off with Nilesh sir and then move on to Devakant sir and Bharat sir once.
As I told, my preferred mode of approach is two-step. I first try to tackle the DME if it is present, and then go on and give the surgery, the phacoemulsification chance. So that exception happens only when there is a mature cataract or a fairly hard cataract that not wait upon. In that case, we don't know if the patient is having DME or not. So again, it becomes it is a catch-22 situation. We give an injection and patient might not be a same grade of diabetic retinopathy as another eye. That what we presume and give. But I have done 1 or 2 cases, and touchwood, the patient had diabetic retinopathy, and I had a backup to show okay, your diabetic retinopathy was not progressing. So that is one thing. My
I think is Nilesh sir audible to the audience?
He is not.
I think we have lost him.
Devakant sir, can you share your experience on the same while he joins?
Yeah, Nilesh, can you just repeat the first question that you asked? Your second question was so long that I forgot the first one.
The first question was what is the experience of IVTA in your practical experience, sir?
Right. So I usually do not use IVTA for my patients. I do them for the pseudophakic CMEs. They work really well. and that too more of posterior subtenon kind of an injection. But what my understanding has of late with the limited experience that I have has formulated that you should inject these patients. I would not inject, a no diabetic retinopathy patient. But if I see a patient with DME, then I would definitely inject, preferably with an anti-VEGF, because that is more affordable, maybe an Avastin along with the surgery. The best choice with certain studies and my clinical experience has shown is definitely an implant like Ozurdex. Now, what we see is that at times there's a rapid progression uh, through the stages of diabetes, and a lot of times we have seen very aggressive progression to a more proliferative form of a disease from a non-proliferative one, and a CME which eventually becomes unmanageable at times, right? So, and a lot of these cases are managed by anterior segment surgeons, and by the time they reach a retina surgeon, it becomes really late to get some good results. So, if my patient is affording and he has got moderate onwards diabetic retinopathy, then I definitely go for an Ozurdex, followed by a anti-VEGF, which is usually a bevacizumab or biosimilar of ranibizumab. If I see DME in my cases, then I definitely inject, and then usually they need injections post-operatively also. Another thing, other rationale for using Ozurdex is because at times we see a very late, progression, which is usually after 3 to 4 months. The patient is doing good till around 2 to 3 months, and then suddenly you see a rapid progression to a more severe form of the disease. So if the patient has an Ozurdex implant, if that thing is taken care of. So I don't recall using triamcinolone for my diabetic retinopathy patients. But yes, anti-VEGFs and Ozurdex I use a lot, and in most of my cases I prefer either moderate upwards and patients with DM.
Okay, thank you, sir.
Now, there are certain other factors also, like as Nilesh and others have pointed out, a good systemic control. Now, a systemic control does not just mean the diabetic status of the patient. Other factors like hemoglobin, blood pressure, the lipid profile, the kidney profile, these things also should be considered. If you see an aggressive form of disease preoperatively, then I would prefer that the senior-most surgeon should take up the case, right? Nothing against the junior surgeons or young ophthalmologists, but whoever is more confident and would hopefully have an uneventful surgery. So it's we should not take any risk in these patients, and yes, and follow these patients up to 2 to 3 months. And another thing is very important is about counseling. You should tell that patient that your diabetes might worsen, and there might be some vision loss following this. It works both ways. It will save you from that progression that happens in case you are unable to inject, and then it re-emphasizes the fact that the patient needs to control the diabetes really well, not just during the 1 week of the surgery, but long after that as well.
Right. Thank you, sir. A lot of pertinent points. Nilesh, sir, you got cut off in the
Yeah,
middle.
yeah. So sorry, my net broke off. So as Devakar was telling, my preferred choice also is Ozurdex in patients not only in diabetic retinopathy but also with retinal vein occlusion, where they are having CME. In the same setting, if I do Ozurdex. Given the patient is affordable. If the patient is not affordable, then only I go with IVTA, because whatever we say, however safe it is not approved for intraocular use. We are using preservative-free triamcinolone, but it is off-label use. So just because of that, the first choice is Ozurdex, only in economic constraint. But if given a choice of preoperative control, my preferred choice is biosimilar or ranibizumab biosimilar that I do, and if I see a good reduction in CMT, then only I proceed with diabetic retinopathy. The phacoemulsification. And if it is a severe NPDR, then again, Ozurdex implant.
Right. Okay. Thank you so much. Bharat, sir, would you like to add something?
Yeah, like few points I would like, and I'll maybe ask few questions also. Although being a non-retina person, already majority things have been shared by the retina experts. But the only thing I like, what I feel like, why people refrain from using IVTA is the incidence of secondary glaucoma. Because it is like second day, usually the IOP shoots up to maybe sometimes 35, 40. So that may and it's not non-FDA approved. Other thing is taking into consideration if you can buy time the grade of cataract glass, and if you want to control pre-op, that is a far better approach consider rather than like injecting in the same sitting and causing the diabetes to progress retinopathy to progress faster. Like if you are able to see the fundus well, NPDR without CSME and all these cases, you can severe NPDR without CSME, you can laser them well. And if you see like the macular thickness, there is diabetic macular edema already listed out. Like better to inject biosimilars or other drugs to control. And other thing, important thing, harder cataract, not able to see fundus, see the other eye status. That may give you a better idea like how the status of the other eye can be. Although there can be asymmetric DR in the other eye also. So, and I would like to ask the retina expert who are using the Ozu drugs regularly, or what is their experience regarding the secondary glaucoma and other side effects and the incidence of.
Did Sir get cut off? No.
Uh, in my clinical experience, I have not seen IOP spike with Ozurdex because it is safe.
Okay.
And but IVTA I have seen a spike in 2 or 3 patients that usually subside. IVTA subtenance I have seen spike that has been constant, but with intravitreal I don't know how, but my spikes came down after 1 month.
Okay. Great.
So
Deepak,
Bharat, I have
your experience regarding the same.
right. In terms of Ozurdex, I've been lucky, but except for one case where eventually I had to explant the Ozurdex and do some vitrectomy. But
Okay.
largely, the IOP spike is not that big a concern. And whenever I've had an IOP spike, I've been able to manage it well with topical drugs, medication. So one case I had to explant. One case, it was not a diabetic case. I had injected Ozurdex for a Coats disease, a 10-year-old child. So that was the second Ozurdex that I had given. And during that, almost in the second month, I had a big, even after maximum medications, the child was having an IOP of 40, which in subsequent follow-ups, when I started that I'll plan a vitrectomy or a glaucoma or shunt procedure, something for that. But then eventually it magically vanished and the IOP was controlled somehow. But it's relatively safe. I've had a good number of Ozurdex injection in these patients, and IOP has not been a big consideration yet.
Right.
Regarding the infection profile.
With Ozurdex?
Yeah, like with these intravitreal plants and
never. I never had an end-off case with Ozurdex. Of course, the Ozurdex numbers are less, 20 anti-VEGF versus 1 Ozurdex, but still the numbers are less. Some of my colleagues have had end-off cases. One of them, few cases are there, but it's not that much.
Yeah, so these are the major concerns, I guess, regarding these drugs. That's what.
And another point is, as Dr. Bharat had touched upon it, the timing of surgery is also important. I always prefer in my diabetics where I see some cataract developing and an early grade of retinopathy, then I try to counsel them for early surgery. Now, once it's a higher grade of cataract and you'll be using more surgery or chances of more complication, then the progression of diabetic retinopathy will be faster. So try to operate these cases as early as possible.
Right. Thank you so much, sir. This was a really lively discussion. With that, I'd like to share my screen once again. And last but not the least, I'd like to introduce Dr. Shriya Dhar ma'am. She has been the monthly mentor for this entire month, guiding Surbhi as well as all of us. I would invite her to summarize the topic, to summarize the article, and to summarize this journal club session. Dr. Shriyadhar completed her ophthalmology residency from Sri Shankara Deva Netralaya, following which she pursued a 2-year fellowship in cornea and anterior segment from the L.V. Prasad Eye Institute in Hyderabad. She is also a fellow of the ICO and currently a cataract and cornea consultant at Eye Care Hospital, Noida. With that, ma'am, I just transfer the mic over to you.
Thank you, Dr. Anuji. Let me just begin with thanking the YOSI Forum and Dr. Nupur for the opportunity to mentor Dr. Surbhi, who I must say has done a fantastic job, considering that this is her first ever attempt to present a journal club. So it's always important to kind of assess the merits and demerits of any study before you incorporate the take-home message into your clinical practice. So going ahead with it, this study does claim that IVTA has a functional as well as an anatomical benefit in using. The problem with the study, which I also think, and I agree with the other panelists, is that the way that they have described the sample size is just very haphazard. It's not very well categorized. More importantly, coming to the point of the progression of diabetes, it would have been a little more pertinent to describe the grade which progresses more. Is there any progression in the no diabetic to mild diabetic NPDR, or is there which category of diabetic retinopathy is progressing more despite any intervention? Also agreeing with the panelist is that Dr. Devakant, as he mentioned, that a good glycemic control is very important. And as well as that, it could have been a little more informative to us if the study could have compared the outcomes of no intervention versus IVTA versus anti-VEGF or an Ozurdex implant. Coming to the statistics, I'm not an expert at it, but yes, the sample size of the patient and again, the grading of the diabetic retinopathy in the sample size is something which is not very clear. It leaves a lot to the imagination. And again, the surgical time and the anatomical data of the OCT is something which is missing from the study, which is again important. We do need to compare the functional as well as the anatomical biomarkers when we take up any treatment for consideration. Another important point, which I think none of us would have thought about, is the pioglitazone, which Dr. Devakant mentioned. So it's very important for us to know what kind of treatment the patient is on, what is the systemic status of diabetic control before the surgery, as well as immediately after the surgery for a period of at least 6 to 12 months, which would also help us in ascertaining that only the treatment given in the ocular scenario, is it enough for non-progression of the status of the eye, or a good systemic diabetes control is something which everyone of us know is very important, correct? And again, thank you, Dr. Bharat, for the excellent literature review. So we do know that IVTA has a role in decreasing the pseudophakic CME, but as far as the diabetic status is concerned, yes, non-affordability is always a question, even in a country like India, where maximum of the population cannot afford the Ozurdex and the anti-VEGF drugs. But somewhere down the line, we do have to compare the non-affordability versus the actual functional outcome of the treatment which is being given. So a comparison study of all these drugs would be really important. And another thing, do we really need IVTA as a phaco enhancer in patients who do not have any diabetic retinopathy? Or can we just kind of observe them? So personally, I have done 2 cases who had mild diabetic retinopathy to the tune of having only 1 or 2 microaneurysms. And I did give them IVTA with the surgery because the microaneurysms were very close to the fovea. They did very well. But again, I do not have anything to compare it to, that if I would not have given an IVTA, would it have deteriorated or would the edema have set in? So many points need to be considered going forward, that giving routinely IVTA when we do have other beneficial drugs who have a varied range of mechanism of action, a better control. So is IVTA really a good drug, considering if we cut out the affordability part? So does leave a lot to the imagination. But otherwise, a very fruitful discussion, and it's not a drug which has lost its importance, I guess, can be used in many places. The only question is, where do you actually give importance to the affordability and where do you actually give importance to the functional outcome of the drug?
Thank you so much, ma'am. Like you said, it's a really fruitful discussion, just echoing your words once again, and a lot of practical points to take home. And this is what we try to do in every journal club, to combine the theoretical aspect, the statistical analysis, as well as the practical take-home points for those joining us. With that, we come to the end of our journal club, and I would like to present a certificate of appreciation to Dr. Surbhi Jain for being the speaker for this session, to Dr. Shriyal Dhar ma'am for being the monthly mentor, to Dr. Shraddha Surekha ma'am for being the research expert for this session, to Dr. Nilesh Kumar sir for being one of the expert panelist members, to Dr. Devakant Mishra sir for being one of the expert panelist members, and last but not the least, to Dr. Bharat Gundani sir also for being one of the expert panel members. With that, I invite you to the next session of the YOSI Journal Club, which will be held towards the end of the month of July. This time we have a topic on uvea. Once again, I thank everyone for their participation as well as for taking out time this evening to participate in the Journal Club. If you are watching this live or recorded and would like to participate in a YOSI Journal Club, the details are on your screen. You're most welcome to take a screenshot and send us a mail. With that, I'd like to end this session.